So I request Dr. Vijay Pratap Singh to take the dais, and Dr. Lalit Verma, Dr. Mehul Shah, Dr. Venu is here, Shamshil, Piyush Bansal. No. Okay. We'll start the show.
Yes, sir.
Okay. Right.
So, good morning, everybody. Thank you, AIOC, for giving me the opportunity to be in this academic feast of cells and flare. Though this is a very lengthy topic, decoding white dot syndrome is definitely a very large topic which I will try to cover within 7 minutes, and it's not possible for me to cover all the entities because there are so many entities ranging from APMPP to birdshot chorioretinopathy. But during my discussion, can you please put my PPT? It's not coming here on the it's on laptop, it's not there. So we'll try to cover the common ones. It's still not there. So as we all know, that white dot syndromes are a group of ocular disorders which are actually characterized by the presence of subtle whitish lesions at the level of choroid, RPE, and or neurosensory retina. And as I have mentioned, there is a very long list of white dot syndromes starting from APMPP up to the birdshot chorioretinopathy. So coming one by one. Acute posterior multifocal placoid pigmentary epitheliopathy. This disease, which is commonly known as APMPP, is usually seen in the younger age group of 20 to 40 years, and the disease is having no sexual predilection. So it affects both male and females and is also found to be associated with HLA-B7 and HLA-DR2. Delayed type 4 hypersensitivity is implicated in the pathogenesis of this disease, and that's why the disease is found to be noted in the patients of autoimmune thyroiditis and scleritis associated with CNS vasculitis, along with the post-vaccination of meningococcal B vaccine. The history of influenza-like prodromal illness is seen in 50% of the cases, and the disease is usually bilateral in nature, but sometimes what happens that this occurs in the other eye after a few weeks, and that is a bad prognostic indicator actually. Mild anterior segment reaction can be seen, but vitritis of mild to moderate degree is usually noted in 50% of the cases. The lesions are creamy white yellowish involving posterior pole, and they are placoid in nature. When we do FFA, these lesions appears to be more numerous as they seen clinically, and there is typical early hypofluorescence followed by the late hyperfluorescence. In the inactive phase, hyperfluorescence is because of RP atrophy and depigmentation. In ICG, both in active and healed lesions, hypoautofluorescence is noted, and again, they are more in number. The disease is self-limited, so spontaneous recovery occurs in most of the cases, but whenever the macula is threatened, we will have to treat them by the means of steroids. In 80% of the cases, we have a very good visual recovery. Multiple evanescent white dot syndrome. This white dot entity is more commonly seen in females than in males, and again, this is seen in the younger age group. Viral prodrome is seen in half of the cases, and anterior chamber reaction along with vitritis is noted in up to 50% of the cases. Optic nerve involvement is very common in mutes. That's why afferent pupillary defect can be present in these cases. The disease is usually unilateral, and there are multiple subtle white dot lesions which are actually made up of microdots, and they can be best elicited by the means of slit lamp biomicroscopy rather than doing an indirect ophthalmoscopy, and uniform macular granularity is the pathognomonic of mutes. When we do FFA, like other choroidal lesions where we get early hypo and late hyper, here we get early hyperfluorescence, and these lesions are arranged like in a wreath manner at the fovea, around the fovea, as well as in the peripapillary region, and they are more in number on FFA and ICG as they are clinically seen. Self-resolved lesions and the visual acuity can be achieved by the 6.9 up to the 6.6. Serpiginous choroiditis, which is an uncommon entity in the countries of European origin, But this disease is very common in India and affects mainly the age group of 30 to 60 years without any sexual predilection. This is bilateral, chronic, recurring, progressive in nature. Anterior chamber reaction is uncommon in European countries, but Professor Amod Gupta et al. Has reported that anterior uveitis is commonly seen in Indian origin patients. Mild vitritis can also be noticed, particularly in the patients of serpiginous-like choroiditis rather than serpiginous choroiditis lesions. The lesions are irregular, grayish-white or creamy yellow, subretinal infiltrates at the level of choriocapillaries and RPE, and they have a propensity to develop around the optic disc and then expanding centripetally in a pseudopodial or serpentine manner, which suggests its previous name, geographical helicoid peripapillary chorioretinopathy. The lesions which are active are usually seen at the border of the inactive lesions. Fundus autofluorescence is a very important tool to assess the activity of the lesion and how they are responding to the treatment, because active lesions are hyperautofluorescence, and when they start healing, they becomes hypoautofluorescence. FFA, typically early hypo, late hyper, and inactive phase, we can get mottled hyperfluorescence. The patients can have CNVM in these patients, so they should be treated by the means of anti-VEGF agents. ICG and OCT, they are not very much having some typical findings which can help us in diagnosing the disease. Systemic steroids and immunosuppressive agents are the cornerstone of the therapy managing serpiginous choroiditis. Multifocal choroiditis and panuveitis usually affects adults in their mid-30s, and the disease is again more common in females than males. The disease is bilateral in nature with mild to moderate anterior chamber reaction as well as the reaction in the vitreous. Multiple round yellowish lesions are seen not only around the disc, but there is a distinct propensity to have these lesions nasally to the optic nerve head, and optic neuritis is seen in about 1/3 of the cases. FFA again early hypo, late hyper, but ICG is typically hyperfluorescence in active lesions which becomes hypo in the healed lesions. But before diagnosing this, rule out TB, syphilis, presumed ocular histoplasmosis, DUS and PORT and viral retinitis. And if CNVM is there, treat them with anti-VEGF. If it is not there, treat them with steroids and immunosuppressive agents. And this is the last entity which I am going to deal. Punctate inner choroidoretinopathy is usually seen in the young myopic women of 20 to 30 years of age. The disease is usually unilateral, but they can be present bilateral. But there is totally absence of anterior uveitis and vitritis, which is the hallmark of PIC. There are multiple discrete lesions which are seen over the posterior pole, and absence of CME or disc edema as opposed to multifocal choroiditis or mutes is again a characteristic to decide whether this is a PIC or this is mutes or multifocal choroiditis. But CNVM is the most significant clinical sequelae which is seen in around 1/3 patients. Again, the lesions are very typical on fundus fluorescein angiography. They are hyperfluorescence from the beginning, and in the later phase, this staining is more. ICG is again hypofluorescence. There is no treatment for the majority of the patient, but whenever there is CNVM, we will have to take care of these lesions either by the means of PDT, anti-VEGF, or laser photocoagulation. So the take-home message is that whenever that white dot syndrome is there, they are always a diagnostic challenge. But ancillary testing by the means of fundus autofluorescence, fundus fluorescein angiography, indocyanine green angiography, by the means of electrophysiological tests, VEP, etc., we can diagnose them, and actually the treatment depends upon the cause and the sequelae. These are my acknowledgements. Professor JB, Dr. SKG Madam, Amla Ma'am, Sudarshan Sir, and Parthapratim Datta Majumdar, who has taught me the nitty-gritty of this subject, and Dr. Shivangi Kapoor, who has helped me in preparing this presentation and collecting all the photographs of all these patients. Thank you so much.
Thank you, Dr. Tomar. You have enlightened nicely, but do you include serpiginous choroiditis and multifocal choroiditis into punctate?
Sir, still the classification still involves them. Though we have a long discussion in Uveitic Society of India, conference, that serpiginous choroiditis at least should not be here in the white dot because they are very large lesions.
Yes. Both multifocal and serpiginous should not have come here. And birdshot retinopathy could have been included in
Birdshot retinopathy I haven't included in my talk because that is very, very uncommon in Indian subcontinent. I
matter
think
as
in last 13 years when I was doing my fellowship under Dr. J.V. sir, I haven't seen even a single case of birdshot chorioretinopathy.
That's fine. Why do you think that hyperfluorescence happens with the mutes and punctate inner choroiditis, whereas APMPP it is hypo followed by hyper?
In APMPP, what happens that there is actually the perfusion of that RP and that layer of the choroid, that is actually hampered. Because of that, we are getting that early hypofluorescence. And the best part of this white dot syndrome, if it is because I think that students are also there. Most of the time we cram that in APMPP we will get early hypo, late hyper like this. Believe me, it's very easy to remember because in all the entire that choroiditic entities, this mutes, this PIC, this subretinal fibrosis and panuveitis syndrome, and Krill's disease, that acute retinal pigmentary epitheliitis, here we get early hyper which persists even in the later phases. That Krill's disease, I have seen one patient and that I diagnosed only on the basis of FFA. That helped me a lot because these lesions are very subtle in nature. So I was thinking that I was...
Let us not distinct the discussion. In mutes, you said it is self-resolving. Are there any cases where the audience should be alerted that they should start on steroids to reduce the complications?
Sir, multiple evanescent white dot syndrome, until unless we are not having any CNVM, I don't think that we should treat them with the steroids. But APMPP definitely, because whenever the presentation in the other eye is a little late, or that macula is threatening, at that time we will have to give these patients steroids.
Two conditions, one is macula or the disc.
The disc is,
These two things, we have less time and if other speakers comes, it will be very...
Sir, regarding APMPP, I would like to discuss something. Amod Gupta sir has a landmark study on serpiginous choroiditis.
We are not going into all that.
Sir.
No, please. Okay. Because we have limited time for each speaker, 7 minutes you extended that and now 1 or 2 questions of discussion